I'm very excited to introduce our first ever Prevention Connection Live Roundtable. I'm Zachary Julius, the CEO of PDI. Hopefully most of you know who PDI is. Pretty simply, we're a purpose-driven organization. We exist so that somebody's mother, brother, father, son, sister, aunt, uncle, childhood lover doesn't get sick, die, or suffer because of what we do every day. As an infection prevention company, we believe in a layered set of solutions and interventions to drive outcomes for healthcare systems, providers, communities, food safety professionals, and the like. Today, we have a rock star panel of people here to talk about the shifting sands in healthcare delivery today. It does take a village to deliver infection prevention, and with budget cuts, lack of training, lack of staffing, and all sorts of external pressures, the world is different than it's ever been before. Everyone will have the opportunity to submit some questions later, but what I'd like to do first is introduce the panelists. First and foremost, our moderator, Dr. Benjamin, who is, I'd like to say first and foremost, I'd like to call a friend, is an exceptional person, a former Surgeon General and a member of the board of directors of PDI. As you heard my mother-brother speech before, one of the things she always reminds us is that every patient is a person. And that's something we'll never forget. And that's why everyone gets up and invests their lives in infection prevention in this community. Stephanie Mayork, President of Mayork Consulting Services. Benjamin Galvin, IP Director at South Tampa Hospital. Michelle DeBreeze, congratulations on your incoming presidency at AVA. Very exciting. And our very own Alice Brewer. Woo, go Alice. A rock star in her own right, and we're lucky to have her. Again, thank you everyone for being a part of this panel. This is an exciting day. I'm proud to have PDI sponsor it. And on behalf of all of our associates, thank you again for participating in the work that you guys do every day. Please look out for social media from PDI for Infection Prevention Week. We have a lot of activities happening, and a little spoiler alert, there might be a gift card or two in there. In any event, I'm going to sign off before I start coughing because I didn't do as good a job at prevention as you all do, and turn it over to Dr. Benjamin with tremendous respect for you and the rest of the panelists. Thank you and have a great hour. I'm looking forward to hearing the discussion.
Well, hello, everyone, and thank you so much for joining us as we celebrate International Infection Prevention Week. As was just stated that I was the 18th, or am still the 18th United States Surgeon General, former Surgeon General, but prevention is very important to me, not just as Surgeon General in public health, but throughout my entire career. I define myself as a family physician. I have a clinic in Alabama. It's been in for the last 30 years. 22 of those years, I was in solo practice. And so I've seen medicine from every level. Even when I was gone away for a few years to be the Surgeon General. As Surgeon General, I released the first ever national prevention strategy. And so it was a way to have a more healthy and fit nation. And so prevention is at the base of everything. Also led the United States Public Health Service, who is devoted to providing prevention and safety for the entire nation. 6,500 officers around the world protecting the public's health. I moved on a little bit to regulatory and licensure. So all of these things is how can we keep our patients safe and provide good healthcare services to everyone. And when I came out of government, I decided to start doing some corporate board work. And as I looked around at the boards that I wanted to be a part of course, PDI fit right into my philosophy of life when we want to prevent illnesses and diseases and infections. And I always say that prevention is the foundation of my work in public health and as a doctor. But health does not occur in the doctor's office and the hospitals alone. Health occurs where we live, where we learn, where we work, where we play, where we pray. Health is in everything that we do. And we can't be a healthy nation if we undergo infections and infectious diseases and illnesses. So let's get started. I want to say hello to all of our panelists and just kind of start with Stephanie and Ben and Shelley. Each of you have a title of infection preventionist. Can you tell us what an infection preventionist is and how you define it, and give us some examples of your experience? Let's start with Stephanie.
Sure. Well, first of all, thanks for having me, and happy International Infection Prevention Week to all of those on the panel at PDI and those joining today. Infection prevention is a profession of subject matter experts that are meant to prevent infections from happening in our workplaces. That is among patients, among family members, visitors, and among our staff. And we encompass, policy and procedure development, education, leadership, quality assurance, all of those different skill sets to help prevent infections from happening. And of course, unfortunately, if they do happen, how we mitigate and control them from spreading to others.
And what's some of your examples how do you do it every day in your life?
Well, obviously, I've been involved in leading a team of infection preventionists at a system level hospital and healthcare organization, ensuring we're implementing all those best practices that are released through peer-reviewed evidence. Recently, I've been supporting the film and television industry in their mitigation strategies to prevent COVID-19 in their workplaces. So I think, as we focus on healthcare, but there's a lot of opportunities for infection prevention. And like you mentioned, our communities, faith-based organizations, schools, and different industries outside of healthcare where prevention and our expertise is certainly appreciated and needed.
Yeah, that's pretty interesting. We'll come back to it. But Ben, how do you define it?
Thank you, Dr. Benjamin, and thank you to the team just for inviting me to be here today, and happy International Infection Prevention Week. In my eyes, infection preventionists are specialists that are trained at identifying actual and potential modes of transmission of infection. And we do that through collaboration. Without our stakeholders and other subject matter experts within the actual facility that we work in, we couldn't do our job. Because infection prevention has such a wide breadth of requirements within the facilities, it'd be impossible for us to be able to do this ourselves. So leaning in our partners within the facility, like respiratory therapy, sterile processing, surgical services, nursing, environmental services, and then also within the industry with our partners with PDI and other companies that help us do the everyday work that we do to help prevent infections.
Well, that's great. How about Shelley?
Thank you, Dr. Benjamin. It's hard to follow up those very concise representations. I think Stephanie and Ben did a great job of answering this. I think for me, coming from a background of hospital molecular epidemiology, and it's exciting to see the other panelists here, we are a diverse group of specialists all rallying around that singular goal of improving patient safety and preventing avoidable infectious and other risk. And I think that's one of the beautiful, beautiful things about our profession is we come about it from many different angles. Many of us work on multidisciplinary and interdisciplinary teams so that we can leverage all aspects of patient safety. So for me, as a background in epidemiology, we know it's exploring the distribution and determinants of disease. As an infection preventionist, for me, my chosen population then is hospitalized patients. And my passion is those with vascular access so that we can work together. I think Benjamin mentioned the partnership and the collaboration throughout our organization so that we can truly identify both the predictors and preventors of complication and help do everything we can to make healthcare as safe as possible for those who have trusted us with their care.
Great. Alice, Shelley mentioned the epidemiology, and you're described as an epidemiologist. Is there a difference?
No, I don't think that there is a difference at the heart of it. Epidemiologists and infection preventionists are both, very interested in understanding the ways in which patients are acquiring these infections and the ways in which we can prevent them from acquiring those infections. And that's one of the great things I love about epidemiology, have loved for the last 15, getting close to 20 years, is that it's such a versatile field. You can really apply it across multiple disciplines. And I'm so lucky that I've been able to apply it in the space of infection prevention and healthcare quality, because I think, my colleagues in those spaces, whatever their background, we have a very similar passion and an interest in making sure that patients are safer and that they don't leave our healthcare organizations worse off than they entered them. And so it's been a fun career field and path, and I love working with this group of colleagues, and I'm so thankful that the three panels we have were able to join us today, and that you're here to help moderate, because I think just the diversity of background and experience is lends to such a great conversation around this very important topic.
I agree. And Stephanie mentioned that the role is kind of shifting from exclusively healthcare to support many different areas like education and the entertainment industry. Stephanie, your previous experience consulting with film and television studios and production and IP needs, what does that say about the shift and how we see the role of IP?
Well, it's funny. At the time I was approached back in May of 2020, I was approached by a hospital epidemiologist mentor that essentially said, hey, returning to work in the film and television industry, we feel like infection preventionists are needed to really help support that. And at first I thought he was joking. I didn't really understand how our skills would be an asset to that industry and organization. But all kidding aside, when you think about returning a workforce to work in the middle of a pandemic and the skills that are needed, implementing workplace best practices, educating and teaching on personal protective equipment options and appropriately donning and doffing. An industry like the film and television industry, they conducted tons of tests and are still testing regularly. So how do you decipher those test results, work with public health jurisdictions to make sure that we're following the guidance as appropriate for wherever we might be working? Those were all new to that industry. And infection preventionists are highly skilled at doing just that. So it was a great reminder to me how versatile we can be and how our skills can really fit well in many different industries. I've had colleagues in consulting that have supported professional sports teams, hotel industries, cruise ships, airlines through the pandemic. And I hope it's a trend that continues. I think we have more education to do on what we can offer. And as our skills evolve as IPs, as we have more professional development opportunities with improving quality, human factors, engineering, that type of skill set that we start to obtain over our career, that we can get in on the ground level of some of these issues and prevention strategies and be called to the table preventatively instead of as the fires are raging and burning.
Yeah, when COVID first broke out, I actually was consulting around with Zillow, basically to help them develop policies and procedures of how to keep their employees and their customers safe. So I agree. I think some of this is changing in the near future. And again, that goes along with health is in everything that we do. Ben, do you agree with that? And do you think the role of IP is elevated since COVID?
Absolutely. I do agree with everything Stephanie said. And I think versatility really hits the nail on the head. Infection preventionists have to be versatile and flexible with everything they do every day, because you don't know who's walking in the facility. You don't know what environmental factors are going to be playing a role. Are we prepping for a hurricane, or are we in the middle of a global pandemic? So literally everything we do, I think it really shined a light on everything that we bring to the table. Whereas before, we may have just been seen as the police, I'm often told, walking around the hospital units and catching people not doing hand hygiene. I think we've really evolved into more of being viewed as collaborators in every aspect of healthcare. Instead of being a last minute thought, we're the first person that they call. And we've certainly seen that even outside of healthcare, as Stephanie mentioned, looking at helping businesses reopen, looking at air exchanges, looking at where to put hand hygiene dispensers. What does quarantine mean? What does isolation mean? What does testing mean? And when do we test? It's really been an amazing thing to see throughout the pandemic, the involvement that infection preventionists have been brought in.
I don't want to leave this topic without just asking you, you're in Florida, so were you guys impacted much with the hurricane?
Luckily, right, I'm in Tampa Bay, so luckily we weren't affected
Wow.
too much. It veered right at the last minute. We know our partners along the western side of the peninsula were certainly affected. So we're doing everything we can to help them. We know that flood damage certainly presents a major risk for infections. So there's been a lot of work from our company on helping mitigate that.
Oh, thank you for that. Shelley, how about you as far as changing of the role of IP for the
Yeah.
future?
I believe the same things that Stephanie and Benjamin mentioned is our importance and our involvement from the start became much more obvious over the last number of years. For one, I think people finally realize that I'm not a dermatologist, and that is the wrong kind of epi, as in epidermis, and they understand. Alice is laughing. You've heard that as well. But really understanding what our role is and where the opportunities are, and just truly encouraging the importance of partnering with us before there's problems to help us be part of a proactive solution. We've seen that at a very large scale within our organizations and also within our communities on a much larger scale to get us involved, have us be part of the conversations on the front end, even when there's just early planning going on. You mentioned in your intro the whole ounce of prevention adage, and it holds so true here because throughout the continuum of care, beyond the walls of traditional healthcare, we can really work together to build patient safety into our programs from day one. And then we can help measure both the processes and the outcomes associated with us, bring us to the table at the front end, and we can really help make things happen.
Great. You know, Alice, with PDI, the customers, I'm sure, shared the challenges that they face around labor shortages right now. Would you say there's a correlation with the healthcare equipment and the surfaces being properly cleaned and disinfected?
So I think there may be an unintentional correlation. You know, we've seen in the healthcare space, there's a lot being asked of fewer and fewer resources. And so just, you know, people can't be everywhere all the time. And so I do think you see people making decisions and prioritizing. And so maybe the surfaces that prior to the pandemic were getting cleaned at a certain frequency or being cleaned to a certain degree, it's lessening, not because people are unwilling to do their jobs, but because they have more to do. And so, you know, you have to prioritize the tasks that are most important and most critical for patient safety. And so, you know, we are kind of seeing that, and it's up to us as a vendor and a company, and you know, my team as clinical experts in the field to try and help our customers figure out, okay, how do we help you with that? We're all infection preventionists on my team here at PDI, and so we've lived that, and you know, so I think we can help bring some strategies as to how to help them make sure that they're doing everything they can.
Do you have any advice on how to streamline these practices and maybe save some time?
Yeah, so I think standardization, I mean, that's one of my favorite words. It has been for a long time. I think that really helps eliminate error and make sure that everybody kind of has the same understanding of what needs to happen and when it needs to happen. And we've heard the word collaboration and multidisciplinary brought up a lot. I think that comes into play here. Most hospitals, most healthcare organizations have a quality department. And so, you know, infection prevention and nursing can really lean on those individuals who are experts in understanding how you can improve practice, troubleshoot areas that might be problematic, identify gaps. And so, you know, really lean on your colleagues in the healthcare space that can help you understand how to become more efficient.
Great. You know, Ben and Shelley, you work in the field. Are there some best practices you found that's helpful with that you can share with us?
Absolutely. I would say Alice really spoke to it well in that we are all infection preventionists. And I think a big part of moving forward with those things like standardization and working with less is that shared responsibility of cleaning and disinfection across the entire facility. Oftentimes you find team members and caregivers not knowing if it's their responsibility, if it's someone else's, what should they clean it with? How do they clean it? Where should they send it? Do they need to walk it down? Does someone need to come pick it up? I think when we can look at both standardizing those practices as well as encouraging a culture of shared responsibility in cleaning and disinfection, we can really begin to address some of the opportunities that have really come up from these staffing challenges that have occurred throughout the pandemic.
Yeah, I agree. Both the labor and the supply chain these last few years created, and honestly, in some cases, continue to create significant disruption in healthcare. We had new staff coming into our organizations that truly had little or no clinical experience as they went through their education processes. Looking from the vascular access side, we know there's growing evidence to support improved outcomes with specialist clinicians. But many of us, the needs of patient care exceeded what we could manage as our numbers surged. So regardless of who was tasked with providing the care, vascular access remains the absolute gateway to healthcare. But in this case, it was further complicated, as we discussed, with so many new challenges as we tried to keep staff safe, manage at times extremely limited PPE. We learned how to optimize outcomes for these very sick patients. Our frontline nursing staff were not only trying to manage the care they always do, but they were also tasked with being environmental services, respiratory therapy, passing food trays, and pretty much every other role in the organization at times as we attempted to limit exposure. So I will echo standardizing what is standardizable in terms of products as well as procedures, and then presenting them to staff in a manner that's intuitive and consistent throughout the organization, to me, is a key approach to minimizing variation and ultimately workarounds.
Great. Stephanie, I don't want to leave you out, but and also any of you who want to jump in, just do. I mean, we're making a conversation, just feel free to.
Yeah, I mean, I would only add that I think anything we can do to make things easier during this difficult time for the frontline healthcare worker is really important. And from a consulting lens, being able to be out there and seeing what different organizations and the different best practices that people bring together in these challenging times has been a great asset. And just something as simple as putting a QR code on a critical piece of clinical equipment on how to clean it, so that people aren't having to search for that information, that the information is right there for the frontline end user to use and have those resources available is important. So as we think about standardizing, it's important, but we have to make those tools and processes available for them at the point of use to help them be more successful during these challenging times through shortages, supply issues, et cetera.
And I would agree with Stephanie on that. I think one of the most time-consuming things is just finding the information out. So if we can cut that in half or even eliminate it entirely, we can absolutely help improve many processes, including cleaning and disinfection across healthcare. And one thing that I think we've really tried to focus on is, particularly for all the newer staff members, is understanding what standard precautions are. And what standard precautions are the minimum activities that we should be performing with every single moment of patient care, whether that's cleaning and disinfection, hand washing, patient placement, respiratory etiquette, and so on. So really drilling down to what is it that we should be doing at a minimum to help prevent the transmission of infections.
Shelley, do you see any additional pressures that healthcare workers are faced with, like now and in the next, say, 12 months? And if so, how can we plan for it?
Looking in my very cloudy crystal ball. So from where I sit, even though, and I always caution when I say, even though our actual number of COVID cases has decreased since our assumed peaks, we're still being impacted tremendously. So 2 or 3 years of changing best practice to something that looked very, very different for a lot of varying reasons. It's going to take us some time to overcome, at least from my lens. And I'm not at all a fan of the phrase "the new norm," nor am I comfortable letting crisis and contingency standards that we've had no choice but to adopt be viewed as acceptable practices indefinitely. Our staff mixes at the bedside have changed dramatically in many organizations, as I mentioned, with nursing taking on a role of even more heroic challenges as we struggle to keep everyone safe. Staffing hasn't yet normalized for many of us, with travel and agency staffing keeping our organizations afloat. But we do need to do some rebaselining, I think, very much on our expectations. Accountability, I think Stephanie mentioned, you know, her key words and her key thoughts on standardization. And I know we all nodded our heads, but accountability is that other piece that we really need to make sure is alive and well in our organizations. Going back and reviewing core competencies, compliance with those competencies, and our accountability. I'd like to see us working with staff to make sure they have the support, the tools, and the educational support so that we can return to the high performance standards that we kept prior to the world going sideways.
So Alice, do you think the challenges are similar in the acute care setting, like the hospitals, and as they are in the non-acute settings, like skilled nursing facilities and long-term care and surgery centers and offices?
Some of the challenges are going to be similar, you know, when it comes to staffing and resources. I think they're similarly challenged in terms of having appropriate levels of staff. I think you're seeing a lot of new infection preventionists, a lot of new individuals to that field, both in the acute and the non-acute space. And so there's some challenge there that'll be similar across the settings, but you have different patient populations in the acute versus the non-acute space and different care delivery models. So that changes the way you address those challenges. So in the non-acute space, you're not dealing with as high acuity patients usually. They're usually more mobile. They're usually, you know, maybe a little bit more independent, and the healthcare challenges that need to be addressed might fall a little bit more on the patient, whereas in the acute space, you know, you are relying more on the healthcare workers to kind of prevent that those infections from occurring. So similar challenges, but the way you have to address them, I think, changes based on the setting.
And with the setting, you know, the healthcare workforce is just like any other workforce. We're limited. And so I really believe that prevention is the foundation of any healthcare system. So it's important that we have education and training and play a big role in that. And we're seeing we need more people in the pipeline. So Ben, what would you do to try to get more young people to go into health careers, particularly around IP? And what resources did you wish you might have had at the start of your career and that others could benefit from?
So infection prevention was actually something that I didn't even know existed when I first joined the healthcare field. So I think the thing we need to start off first is really even bringing light to the fact that it is a career path for many types of healthcare professionals. Really, there's a movement towards diversifying the types of professionals that actually move into the infection prevention space. So really focusing on the messaging that it's something that's exciting, that it's something that is foundational and something that is something that's going to bring you a lot of, in my opinion, happiness to see the amount of patient safety outcomes that you can really improve on. We focus so much on both device-related infections. We look at communicable diseases, vaccine preventable diseases, preventing infections from environmental factors during construction or natural disasters, looking at device reprocessing and what does that look like within your facility. There's so much going on with infection prevention that I think we just need to begin speaking about it more and spreading the word, because anytime I talk to other healthcare professionals about what I do, you could see that light in their eye really sparkle, because they get to realize how much of an impact they can have on the entire continuum of care as it relates to both patient outcomes and the safety of other caregivers within those facilities.
You know, increasing health careers has been another one of my passions, but when it comes to minorities, particularly physicians, while 30% of the nation's population is minority, less than 7% of the physicians are minority. Similar numbers for nursing and pharmacists. And I'm sure it's even much lower for IP That percentage for physicians is the same percentage as in the Flexner report of 1910. So we really need to encourage young people to go into health professions, and they can look up to people just like you. Shelley, I know you're involved with the Association of Vascular Access. How are they playing a role in education?
Oh, awesome. Thank you. That is a question I love to hear and I'm happy to address. So AVA's mission is to protect the patient, educate the clinician, and save the line. So education is literally built in to our mission. We just, I guess it's been less than 2 weeks ago now, we finished our first in-person scientific meeting since COVID. We brought clinicians from around the world together to learn from one another. We have dozens and dozens of local and regional networks regularly providing opportunities for continuing education for our members. I was actually at one last night. I'll be at another one tonight to really bring our members and others interested in learning more. We have monthly webinars. We publish a quarterly peer review journal. We have a couple different newsletters and a pretty robust series of regularly updated position papers on a completely different scale, since we really need to get at healthcare providers at their very first moments of their profession. We just officially launched a peripheral IV curriculum in partnership with BPRON, which is a 4-part certificate program that will provide absolutely free foundational knowledge about peripheral IVs for any interested pre-licensure program. So nursing, medicine, respiratory therapy, paramedics, literally any pre-licensure healthcare program around the world. And one of the really cool things with this is that students who participate in this curriculum actually receive a free AVA membership, which then gives those students access to our peer-reviewed journal and education offered throughout the year. And I think the last thing is that we are also well on our way with our goal of publishing clinical practice guidelines for vascular access as one more avenue for sharing information, which hopefully you will see late next year.
Great. So Alice, I'm gonna put you on the spot a little bit. You know, in the PDI boardroom, we're always talking about all the research and the information that we have, and we really should be sharing that information. Can you tell us how PDI is addressing trying to educate or provide some of this education for our customers?
That's a great question. And I love what Shelley was talking about. I think it's important to hear from our professional associations. I know APIC, who I'm very involved with, does a lot around education. And on the PDI side, we really try and partner with those industry organizations, with our customers, with healthcare workers in the field to make sure that the education that we're developing and creating is appropriate and useful for infection preventionists in the field and nursing and other healthcare workers. For example, we know we've talked already today, there are a lot of new IPs in the field. And I can remember as a new IP, and I bet Stephanie and Shelley and Ben also remember, it can be a little bit overwhelming, you know, wanting to know, okay, what do I need to know? Where do I find it? Where are my resources? And so, you know, we've put together a new course at PDI developed by Holly Montejano, who's on my team, is an excellent resource for new IPs to the field. So what do they need to know? Where can they go to find that? We'd like to, you know, continue adding resources to that, you know, the good websites to bookmark so that you know, can have access to that information. And so I think it's important to develop that education with an eye towards collaborating with those frontline healthcare workers, because we want to make sure that that education is relevant and will provide some value to them and help advance the field of infection prevention and protect patients.
Great. So we're gonna, you know, I want to continue, but I want to remind the audience that we want some interaction with you. And so if you have some questions, and we'll continue our conversation for a few more minutes, and then we'll kind of open it up for some questions. So be thinking about if you have any questions or comments. So Stephanie, product innovation is the core of companies like PDI to enable the healthcare workers to perform their duties and stuff, you know, efficiently and effectively. In your experience, what innovation would you say has been a game changer for infection prevention? And what would you like to see as a new innovation?
I could be selfish and say, I think electronic surveillance as an IP and as IPs as a professional role has been transformative in allowing us to collate data, pick up on issues, and spend more time at the bedside and with our frontline clinicians intervening. But I think in retrospect, looking at the pandemic and what it has done to healthcare associated infections, where we've had this great decade or 15 years of amazing performance improvement, and we've backtracked. And when I think of product innovation and the tools that helped us get there, were really those that made it easy for our frontline clinicians to implement the best practices at the bedside, whether it's scrubbing a hub, whether it's optimizing a patient before surgery with chlorhexidine gluconate or decolonization. All of those frontline products have really been a partner to us in moving our patients and prevention in the right direction and trying to target these infections from happening before they start. I think as we progress through the pandemic and reinstitute some of these best practices and these products that have been so instrumental, it's important to think about how we can mistake-proof the process. How, as we design new products, can we put those flashing lights and visual cues and mistake-proof those interventions to allow our frontline healthcare workers to always use the right product at the right time, at the right interval, to support infection prevention in our patients.
How about any of the others? What do you think?
I completely agree. I think innovating ways of actually educating and tracking that we're doing it properly is so foundational to making sure that we're even if we make the best wipe in the world, are we even using it correctly? Is it staying wet long enough? Are we cleaning first and then disinfecting? Innovating ways that can help us as infection preventionists and leaders on the unit, and even the frontline staff, to know that they're doing it correctly as well, I think is very important, and a route that I think innovation needs to move towards.
I think we're all very unified on that. You know, we've seen what's happened through the forced variation of care practices that happened over these last few years. So we've used the word standardizable. I love mistake proofing and getting out and actually directly observing, whether you call it shoe leather epidemiology or going to the Gemba, but out there watching these episodes of care and making sure that our processes are right, because our goal is to prevent the infections, not chase them. And we can't get that from being closed in an office and doing a chart review versus actually interacting with the frontline staff and seeing where their struggles are and also their successes when we're able to spread the wins as well.
And I would add, kind of going back to the staffing challenges, I think we all need to, not just as infection preventionists, but hospital leaders in general, understanding that the workforce is so new, and that means that they are much more likely to get burnt out or get defeated, and really trying to focus on how we can address opportunities and education without running them out of the hospital. Because retaining that staff is just as important as hiring it. So I think that's something that we all need to kind of focus on, and I'm sure many infection preventionists are focusing on the best ways of educating and tracking opportunities and addressing them to help really boost up that new staff that's coming in, so we can continue to really get that great, amazing healthcare talent into our facilities that are going to be able to do the processes correctly.
Alice, you know, at a high level, are there any trends that PDI is looking into from an innovative perspective?
So just like with education, you know, the intent and the, you know, our desire is always to develop and look at innovation in partnership with our customers and healthcare workers in the field. So, you know, exactly these kinds of conversations we're having today, you know, wanting to hear from those people that are actually working with patients, that are using the products and understanding what would help them do their jobs better, would make their jobs easier, you know, efficiency, time, those are all things that are becoming critically important in the healthcare space as resources are shortened. So, you know, look for some exciting new things from PDI soon that, you know, have come from direct conversations with our customers and patient care workers that hopefully will help make their lives and jobs a little bit easier.
You know, many of us talk about the fact that much of healthcare is moving into the community-based care and value-based care. It's basically forcing healthcare providers to rethink their strategies, things like ensuring that virtual care options are available. What advice would you have for the healthcare workforce to adopt this new blend of inpatient, outpatient, community, and home-based care? Shelley, or
I think the best way, at least for me to start to address that, is the way we've always done things has really never served us well. And that's become apparent in the last few years. So I really encourage my peers and our peers to stay open to these shifts and help lead the changes. We have to ensure that excellent care is available in many, many different settings, locations, and formats that were never really part of our conversation. So many of us are learning together. And as we explore these shifts, we have to get comfortable being uncomfortable and asking lots of questions. I've never been one to live in the gray, because a lot of what we do historically was black and white, but that's no longer an option in our world. And we learned that very, very much over the struggles we've had. So it's new territory for all of us, making sure that your infection prevention team has a seat at that table as these changes are being made and discussed. So we have all the perspectives considered when making the decisions and setting up the program. Because as we said earlier, it's so much easier to ask the questions before something is put in place and before we're dealing with unintended consequences of what should have been a really good idea.
Alice, are you seeing new disinfection expectations from customers as a result of this?
So I think that like I mentioned, I think there's a need for things to be as efficient as possible, to save as much time as possible. And I think as we're seeing the trend of healthcare occurring, not necessarily in the hospital, it's occurring more at home, in the community, in the clinic setting, that the responsibility for some of those, using some of those products, is falling on the patient. So it needs to be really simple and easy to use, usable at home. So I think those are some of the expectations that we're seeing. And I think this trend of healthcare occurring outside of the hospital is just going to continue. So I think that needs to be something that we all pay attention to, making sure that this is something that patients can do, and we can trust patients to perform some of this if we can't be right there with them.
Exactly. And we're seeing right now the data is forecasting and foreshadowing that we might have a harsh flu season here in the United States, since Australia now is coming out of their worst flu season in 5 years. What practices and preventive measures in health systems and long-term care facilities can we implement ahead of the flu season? And I guess maybe whoever wants to take it, Stephanie, maybe.
Sure. Yeah, so the good news is with flu, we know it's coming, right? So we have the South Hemisphere data to help support that this might be a doozy of a year. You know, dusting off all of those plans, making sure that we are communicating with our patients in digestible chunks, and our staff. I think through COVID, you know, messaging has been an important learning from this, and how do we get important information to people that's digestible, actionable, that is evidence-based, is really important. Obviously, offering easy access to vaccine in long-term care is very important for both the residents and the staff who work there. You know, with what we're hearing being called the twindemic of a bad flu season along with COVID-19, really looking at those surge plans. It's been since last winter or the early spring that we've really probably had a surge to deal with. Where will you put flu patients? Are they going to commingle with COVID patients and residents? All of those things. And then obviously anticipating, again, more supply chain issues. You know, do they have enough viral media, alcohol-based hand rubs, gowns, gloves, masks, face shields? All of those things that we can prepare for ahead of time should hopefully help mitigate a rougher than normal season.
What about the role of the multi-drug resistant organisms, particularly in long-term care facilities? Can you speak to that a little bit too, with this environment, how environment plays a role in that?
I think it's been very well established that the environment is absolutely an important reservoir for multi-drug resistant organisms, right? We know VRE, our Acinetobacters, our KPCs, and now we have Candida auris that complicates things as well. Those organisms persist in the environments for long lengths of time. And I think long-term care and LTAC facilities are a unique challenge, because you think about acute care where we can turn over a hospital room with length of stay maybe every 4 days, every 5 days. Of course, you might have a few outliers, but in long-term care, these are the residents' homes. And in the LTAC population, you might have people staying months to years. So how do you get into those environments, clean them effectively and appropriately while keeping that home-based atmosphere? People are bringing in a lot of soft surfaces, recliner chairs that maybe our normal disinfectants don't work appropriately on. So with developing those schedules, making sure they have the resources to accommodate what might be best practice in those situations is a real challenge. And then you have semi-private, or triple-based rooms and not a lot of private rooms that complicate the spread of germs in that environment as well. So, I think when you're thinking about cleaning and disinfection and MDRO prevention in those settings, really, again, looking at a quality improvement program and going out and observing what's actually happening in policy, what's actually happening versus the policy, and working to improve the process over time, whether it's just a small facet of a cleaning and disinfection program, or you look at the whole thing overall. There's definitely improvements to be made in each of those, whether it's a daily room clean or a terminal room clean, and how we can help reduce MDROs.
And Alice, is there a silver bullet that'll address this, and what's the bundle approach?
I wish there was a silver bullet, but that would make all of our lives a lot easier. But there's just not. There has to be a layered approach to preventing infections and healthcare quality. So bundling different strategies, different interventions. And the reason we need to do that is because not every intervention is going to be executed perfectly, and it may not address every element of risk to that patient. So you have to have multiples of them to make sure that you're really preventing as much risk from getting to the patient as possible. It's that classic Swiss cheese model that we see in healthcare quality. A lot of, there might be holes in each individual layer or strategy, but if they're layered together, the risk might not be able to reach the patient through all the holes. So that's what we, I think, refer to in infection prevention and healthcare quality as kind of a bundle or a layered approach, is just making sure that you're including multiple things so that you are minimizing that risk to the patient.
I'm going to just ask one more question and then move on to some audience questions. But Shelley, do you feel patients can take a larger role in their healthcare when it comes to prevention? I know my answer to that, but I would like yours, because right now patients can do things with technology. I can check my O2 sat with my phone. I can, get my heart rate, even doing an EKG right here. I don't have to be in the hospital. So what do you think about patients?
Yeah, as far as helping prevent infection, absolutely. It would be great, but it's probably also easier said than done. Yeah. So creating an environment that encourages patients to speak up when they have questions or concerns across all of our care settings is absolutely critical for this to happen. I think we've all been at the receiving end as the patient in the bed or in the exam room and not felt comfortable saying, hey, I'd like you to wash your hands, or can you wipe that down before you see me or touch me? So having visible reminders for things like hand hygiene are a start, but also teaching the staff and the patient what to expect during care of invasive devices and giving them permission and encouragement to speak up for breaches. They need to know what good looks like and what right looks like so that they can care for themselves, but also be empowered to speak up, and that staff are prepared to receive that feedback and information in a constructive and non-confrontational manner. It's a heavy lift, but it will take all of us working together, I think, to see these outcomes really get to where we all want them and need them to be.
And you guys can jump in and answer any of these questions, or that one, or any of the other. One of the first questions I see is, what are some of the most important issues needed to address IP in the future? And we kind of talked about it a little bit, but any?
I think, in my opinion, I think staffing is not only an issue for the frontline staff, it's an issue for infection preventionists. I know a lot of infection preventionists really got burnt out from the incredibly difficult period of time when we were working through the acute stage of the pandemic. And then also getting that support from hospital leadership. Some of what's been talked about today is actually getting to the point where we can observe processes and ask questions of frontline team members, and we can't do that from our office. So getting that support from leadership to really help develop an IP program, bring in more FTEs, purchase innovative technology that really helps save time for the infection preventionists so that they can be boots on the ground and really addressing opportunities before they happen.
Next
I'd
question.
also,
Oh, go ahead. You want to respond?
I'm just going to really quickly say, making sure we're expanding and doing our risk assessments. It's getting to be the end of the year when we'll be doing at least semi-quantitative risk assessment for our programs and understanding the risks that exist for our patients beyond just what our state or federal mandates are. There are more ways for us to help reduce harm in our patient population than just those that are currently mandated. And so as we look and explore and look for opportunities to improve, being open to what the data shows us, where our opportunities are, because there is so much work still to be done.
Next question says, since surfaces are not the primary mode of transport for COVID, per the CDC, of course, would you say there's more relaxed awareness around surface disinfection? And if so, is that dangerous?
I would say for all organisms, not just COVID-centric, any relaxing and decontamination of the environment would be a big concern for me. Making sure that our high-touch surfaces are cleaned regularly and disinfected regularly, regardless of what we think we know about a patient's infectious status. So any weakening of our protocols with the frequency and the thoroughness of that process, I think, would be very concerning. And so we've talked a number of times with making sure we're measuring the processes, understanding we have a number of novel ways to do that when it comes to surface disinfection, but really making sure that we don't shy away from that, because there's more at stake than COVID with what our patients are bringing in and the opportunity to transmit things throughout our organization.
Exactly. And not only we want to prevent infection, but we also want things to be clean. I mean, it's just kind of basic cleaning. And so it just kind of makes sense. The next question is, what's the biggest threat for infection prevention?
I mean, I would say something that's certainly become concerning from my point of view is this reemergence of diseases that we thought we wouldn't probably see again, like polio virus, and now we're having this monkeypox outbreak. I think we need to really kind of look at what are we doing as a community to help protect each other. And it all starts with education and understanding those very basic principles of infection prevention, like getting vaccinated, cleaning our environments, cleaning our hands. And really focusing on that prevention aspect of infection prevention and not just reaction.
So I'm going to just add a little bit, because we're running out of time, to that question, in that we see a lot about good bacteria, and there's a lot out there about probiotics and all the good bacteria. Are we being too clean? Are we running? Is that a risk in the future? Or can anybody speak to something like that?
I think it has a lot to do with common sense, right? You know, when we're at home in our home environments, do I want my kids to go out and play in the mud? Of course. Do I want them to have those experiences and exposures to different allergens, et cetera, that can help boost their immune system? Absolutely. But I think when it comes to healthcare and protecting patients that maybe are immunocompromised, that have lines, tubes, drains, you know, that is the environment in which all of those best practices need to be practiced to a T to help prevent and break that chain of infection from happening. So I always tell people, no, do I disinfect my whole kitchen? You know, of course not. Do I focus on a few key high-risk areas? Of course. So I think it's like when I've heard the term COVID common sense, you know, if you're in a crowded situation, put that mask on, wash your hands, be mindful of symptoms. It's applying that common sense across the spectrum of our personal lives and in the healthcare environment.
There's a couple of more questions that are pretty good, but climate change and so kind of things. But we're kind of run up on time. This has been good conversation. I want to give each one of you like 30 seconds to give us your pearls of wisdom, if you will, before we conclude. Who wants to start?
I think I'll start. I just want to encourage everyone as you're growing in your infection prevention career to not be afraid to dig into areas of expertise or an area of the healthcare system that you might not be familiar with. People are really open to share days, sharing what they do on an individual level and as a team level, department level. And it's really helpful to get in there and see what's happening across the spectrum of healthcare and include yourself. You know, don't ask for permission, just say, hey, I'd love to come in and spend some time with you and see how you're doing this work. And you'll be surprised at the opportunities that develop and the expertise that you take away from those types of experiences.
Absolutely. And I would say, again, with the staffing challenges that we're seeing, anyone that's interested in infection prevention, oftentimes the hardest part is knowing where to start. So definitely reach out to either your local infection preventionist if you work in a hospital, the local APIC chapter, which is our professional organization, or even on LinkedIn. Just reach out and see what we can do to help you kind of get on the right path. Because we want people who are passionate about infection prevention getting into the field. We don't want it to be a second thought or something, let's try it and see what happens. People who are passionate bring that passion to the front line when we're discussing and educating basic infection prevention practices. And it's certainly better received when it's from somebody you can see their passion and interest in the field.
I love it. And there are so many different pathways to infection prevention. And we're really lucky right now because fairly recently, APICS actually published an outline for an internship program, basically in infection prevention. So organizations who are wanting to help bring that next generation up, there's a tool we can use that outlines a program for us. Partnership for those of us who are already in the role is critical. We're experts in our field, and many of us even more so within a subspecialty that we bring to the organizations we serve. Stephanie said seeking out those in other departments with an equal passion for improving patient safety and outcomes, getting involved with other associations and organizations to bring our messages beyond the traditional. For myself, I work heavily with vascular access, with infusion nursing, to make sure infection control is a part of every single conversation we have when we're planning access. Not being afraid to ask lots of questions, ask for demonstrations and explanations as many times as you need to, because we are all always learning. So find a mentor or be a mentor, and together we can continue to drive things to the ultimate goal of complication-free patient experiences.
Great. Alice?
I love everything that Stephanie and Ben and Shelley said. That's such wise words. And I think I would add to that to continually educate yourself and dig into the research, seek out those opportunities, whether it's a journal that maybe you haven't read before or research that you're not familiar with, or a CE course on a topic that maybe you don't have as much experience in. So really just continually look for those education opportunities, learn about best practice and how you can apply that to your role within your specific organization. And I love what Stephanie said about collaborating and partnering with other groups and organizations and disciplines within your facility. I learned so much from the nurses that I've worked with and the environmental services staff that I have worked with, because that's not my area. And so it's wonderful to bring that then to keep that in my tool bag as well.
So for those who we didn't get to your questions, we have them, and I will try to respond to you individually. Hopefully we can get staff to do that. But I want to end with a poem. Basically, it's by an unknown author, and many of you probably heard it. It's called God Meant It. and it goes like this. I have only just a minute, only 60 seconds in it, forced upon me, can't refuse it, didn't seek it, didn't choose it, but it's up to me to use it. I must suffer if I lose it, give account if I abuse it. Just a tiny little minute, yet eternity is in it. I hope each of you will take your God minute and make a difference so that just like PDI, you and your organization can be the difference. Again, thank you all for joining us today, and thank the panelists for a great conversation. I really enjoyed being with you, and stay in touch. And I hope this is the beginning of our continuing conversation. So, thank you, everyone.
Thank you
Thank
so
you
much.
so much.
Thank you.